Thumbs up if you can hear us.
So folks cannot hear us? Lisa, you can't?
Marty, we can hear you, but it's quite faint. We're picking up a bit of background noise from others in the room.
Just the background noise. Maybe it'll get better once the background noise stops.
We can try again then.
Can you hear that tapping? Now can you? Can you
Kathy, we can hear you clearly there. What we're picking up on is background conversations.
Got it. It's the background. It's the background.
Good afternoon, everybody. We're just waiting to have a quorum of committee members, so don't interrupt your conversation. Talk amongst yourselves.
We'll
I'll let
be
you know we'll
ready
start
soon.
soon. We're not I'll let you like this.
We're very
Wow. one more question for the folks on Zoom. Are you seeing the preview slides?
We are, Marty. I think what you'll want to do is just flip the display settings.
Sorry, flip it to what?
Display settings. So if you go to the top of your screen, you'll see a menu. Yeah, go there. And then swap.
Does that work?
I think it's just taking 1 minute to process on our side.
Now it
All right,
looks,
now we see the big slides.
but we don't, so I need to swap it back or do something else.
If you go back up to the top, what you might want to do is simply duplicate and then
Okay,
just see it from the big slides instead of the preview slides.
It's been on the screen. Now it's.
So now we're seeing the preview slide. So,
give it a minute.
okay.
And now we are ready to begin.
Now we see the big slides.
Thank you.
Okay, good afternoon, everybody. Welcome. Wow. Good afternoon, everybody. Oh, nice, thank you. It is summer, life is still busy, that whole farce of like everything slows down, malarkey.
Yes.
I just want to acknowledge that's malarkey, I'm sure for all of us. Thank you for making time for this meeting this afternoon and getting yourselves here. Let me share with you our agenda for the day. Maybe. Did I skip a slide?
No, I just switched them because
Oh,
you can.
good. I'll bounce around. Our agenda for the day, we're going to, some of you, for some of you, this may be repeat, but we're going to share the most recent data from the Department of Health of overdose data for the state through the last last calendar year, 2022. We will then have some pretty meaty updates that I think you all will find quite valuable as we go into the preparations of making recommendations for FY25 spending. So we'll look at the status of funding, spending as of fiscal year end as we approached on June 30th, the end of FY23. We will have a presentation of initial input from the Governor's Overdose Task Force. As you know, they provide significant and meaningful input to us to help us make determinations on how to allocate funds. We will continue the thread of conversation that we started at our last meeting on racial equity and how to infuse principles, equity principles into our deliberations and our work. And then we'll close out with just a few updates in preparation for our July meeting. So let me now go back and introduce myself, Carrie Burgess-Feliz. I'm the chair of the committee. My day job is overwhelming. No, my day job is as the vice president for community health and equity at Lifespan. And I will actually allow Dr. Serbo to introduce first and welcome him as our committee representative from Buddha. This is his first meeting in that role, and allow you to introduce, and then we'll go around the table.
Thank you. I'm Louis Serbo, acting director of BHDDH. Many of you I know from the community, and I worked at TOC and other places, so it's nice to see you all here. And thank you for welcoming. Be glad to work with you on this committee. Thank you.
Kate Michaud, I'm the town manager in Warren, and I'm representing Bristol County.
Good afternoon, Matthew Moynihan, Chief of Policing South Kingston and representing Washington County.
I'm Bob Odling with the town of East Greenwich, and I am representing Kent County.
Joe Pratt with the Boys and Girls Club in Newport and representing Newport County.
Rachel Newman Green, acting director of the City of Providence Healthy Communities Office, and I'm representing City of Providence.
And we welcome you also to your first meeting. Thank you.
Josh Miller representing the state senate.
Hi everyone, I'm Brandon Marshall. I'm a professor of epidemiology at Brown, and I'm an expert advisor on the committee.
And good afternoon, I'm Julie Hamill. I'm the state court administrator, and I serve the committee as the Chief Justice's designate.
Welcome, everyone. A slide unfamiliar to no one. We are about to be in our most exciting time of welcome, Maggie, of generating recommendations for FY25 spend. The conversation today, the conversation in July, and then ultimately the vote we're expecting this committee to vote to approve a set of recommendations at our August meeting. As I started this meeting saying, you know, nothing slows down in summer. Of course, we're gonna have most important meetings, conversations, and decision-making over the summer months. So apologies if it feels like I'm a little bit of a stalker around meeting attendance. It is purely just to get a sense of if we're gonna have a quorum or not. So we've learned a couple of things. Number one, as you know, I'm a non-voting chair of this committee. That also means I'm a non-voting representative for the purposes of constituting a quorum. So we need 9 members of the voting members present in order not just to vote, but also to conduct business, even if there's no votes on the agenda. So that's why I'm a little bit of a stalker. That's why we don't start the meetings and hold the meetings unless we have a quorum. So apologies if it feels stalker-esque. Okay, let's dive in because we do have a full agenda. We have Heidi Waddell from the Department of Health who's going to present via Zoom data, overdose data for the state of Rhode Island, so that we are going into our conversations. And if you're all kind of setting your minds to be thinking about recommendations, we're going into that recommendation process with a mindset that includes the most recent data on overdoses, including disparities in overdose data. So Heidi, are we pinning Heidi to the screen as she presents?
We can.
I'm gonna try to show off my Zoom skills. Let's see if I have them. Heidi,
Yes.
if you can you unmute yourself?
Yep, can you hear me okay?
You can. And let me see if I can pin you. Yeah, no, I don't have Zoom skills. I might not be able to.
That's fine. We can
But as
see
long
you.
as you're the only one speaking, Heidi, you should continue to be the small square in the screen. Thank you so much for joining us, and I will let you take it away.
Yeah, and thank you for having me. I'm glad that this worked out and that you can hear me okay. And good afternoon, everyone. Ahead of time, I apologize for anyone who has already heard this presentation. But today I will be sharing, as stated, the 2022 accidental drug overdose data from the Rhode Island Office of the State Medical Examiners. You can go to the next slide, please. Thank you. So just before I start, I would like to take a moment just to remind ourselves that these numbers that I'll be presenting do represent fellow Rhode Islanders whom we've lost, and they are our families, family members, friends, coworkers, neighbors, and other members of our Rhode Island community. And I'd just like to keep that in the forefront of our mind as we assess the monumental impact that drug overdose has had in Rhode Island, especially over the last few years. Next slide, please. So today I will be presenting data as stated from accidental drug overdose deaths that occurred from January 1st of 2022 to December 31st of 2022. And I will be sharing general trends, demographics of the decedents, the setting in which overdoses occurred, substances that contributed to the cause of death, and then just reviewing some overall conclusions. These data come from the Office of the State Medical Examiners, and the cause and manner of death are based on clinical judgment, experience, and consideration of decedent autopsy results, toxicology testing, scene investigations, and decedent medical history. And we report on drug overdose deaths, which are determined to be accidental and do not include overdoses that are classified as suicides, homicides, or have an undetermined manner of death. Next, please. So as of today, 434 individuals lost their lives to accidental drug overdose in Rhode Island in 2022. And though this number is high, the initial projection of lives lost to overdose was 492, as seen in the red portion of the last bar. And this is based on a 13% increase in fatal overdoses in the first 6 months of 2022, compared to the same time frame in 2021. Next slide, please. And this is a less than 1% decrease compared to 2021, which had our highest number of overdose deaths on record for the state. And though this is only a small reduction, this will be the first time we've seen a decrease in deaths since 2019. Next slide. This slide shows the number of overdoses occurring by month and year. Overdoses in 2019 are shown by the gray bars. 2020 is shown in yellow. 2021 is shown in green. And 2022 is shown in blue. And as we expected a large increase in the number of deaths based on January to June of 22 overdose counts, we closed the year with an overall reduction. And it is evident that there was a notable variation in overdoses from month to month. So in the red boxes, I've highlighted that almost every month in the first half of 2022 had a greater number of fatal overdoses than the same month in the previous year. And there was an increase in overdoses in January, March, April, May, and June in this time period when compared to 2021. The most notable increase in this time period occurred in March and in June. And for the second half of the year, there was only an increase in overdoses occurring in December when compared to 2021. Next, please. And next, we'll be looking at demographic trends for overdoses occurring in 2022. So this figure shows the rate of fatal overdoses among Rhode Island residents by the decedent's race and ethnicity. And rates allow us to compare the burden of overdose among groups while accounting for changes in the underlying population over time. And please note that this graphic was created using data from the Office of the State Medical Examiners, which captures race and ethnicity information from initial death reports, medical records, and other assorted records requested during a death investigation. However, we will be working with the Executive Office of Health and Human Services to obtain race and ethnicity information from their multi-agency race and ethnicity data set, and we will be recalculating these rates based on that information. So here we can see the rate of overdoses among non-Hispanic white individuals are shown in blue. The rates among non-Hispanic Black individuals are shown in yellow, and the rates among Hispanic or Latino individuals are shown in green. And we can see that the rate of fatal overdoses has generally increased across the three highlighted groups since 2018, with the highest rates consistently occurring among non-Hispanic Black individuals each year. I would like to note that the rate of fatal overdoses has increased by 50% among Hispanic or Latino Rhode Islanders from 2021 to 2022. And the rate of fatal overdose has remained the same among non-Hispanic Black individuals and has decreased by about 10% among non-Hispanic white individuals in this time period. Next slide. Thank you. When we look at the rates by decedent age category, we can see that the rate of fatal overdose has continued to increase among Rhode Islanders ages 55 and older, as highlighted in the red box. And in 2022, the rate of fatal overdose was highest among Rhode Islanders ages 45 to 54. Thank you. And you can actually click again. Thank you. And in 2022, 72% of individuals who died from an accidental drug overdose were male, which is similar to trends in previous years. Next slide, please. And next, we will be looking at the settings in which overdoses occurred. So we separate settings in which the fatal overdose occurred into three categories: private, which includes someone's personal residence; semi-private, which may include hotels, shelters, treatment facilities, and prisons; and public, which includes businesses, roadways, etc. And if you could click one more time, thank you. In dark blue, you can see that 84% of overdoses occurred in private locations in 2022. In orange, 6% occurred in semi-private locations, and in gray, 10% occurred in public settings. And these trends are similar to findings from previous years. Next, we'll be looking at what substances contributed to the cause of death for overdoses over time. And in the coming weeks, the state health laboratories will be implementing a panel to detect xylazine, which is a non-opioid tranquilizer, and in fatal and non-fatal overdose toxicology results. We will be sharing more information on xylazine when it becomes available. However, xylazine data is not included in this presentation today. So in 2022, any opioid, which includes fentanyl, contributed to approximately 8 out of every 10 fatal overdoses. Next slide, please. And last year, fentanyl contributed to 3 out of every 4 fatal overdoses. Thank you. Methamphetamine contributed to 1 in every 20 overdoses. Alcohol contributed to 1 in 4 overdoses. And cocaine contributed to 1 in 2 overdoses. Among individuals who died from a cocaine-involved overdose in 2022, we found that 74% of them also had fentanyl contributing to their cause of death. And finally, when we look at the types of drugs that contributed to cause of death, we can see that illicit drugs continue to drive overdose deaths. 66% of fatal overdoses involved illicit drugs alone in 2022, and the proportion of overdoses involving prescription medications alone has remained relatively stable since 2019. Click again, thank you. When we look throughout the Northeast region, we can see that changes in fatal overdose counts from 2021 to 2022 have varied by state. So based on preliminary counts from state and CDC dashboards, Maine, Vermont, New Hampshire, and Massachusetts have experienced an increase in overdose deaths since last year, and New Hampshire and Connecticut have experienced a decrease. Next slide, please. So in conclusion, fatal overdoses involving any drug in 2022 decreased by less than 1% compared to 2021. The most impacted individuals were males, those ages 45 and older, and non-Hispanic Black individuals. The rate of overdose among Hispanic or Latino individuals and individuals ages 55 and older increased. Most overdoses, continued to occur in private locations, and fentanyl continued to be involved in most fatal overdoses. Next slide, please. And our team will be making maps of these fatal overdoses. We're in the process of doing that right now. And these maps will be uploaded to the Rhode Island Department of Health Drug Overdose Surveillance Data Hub in the near future. And that can be used to find additional fatal overdose data for download, heat maps, etc. And data can also be found at preventoverdoseri.org, as I'm sure many of you know. And thank you for your time. I think I can leave the rest of the time for any questions that people may have.
So you will have, thank you so much, Heidi. And you will notice that there are multiple opportunities for public comment on the agenda today to make sure that we have ample opportunity for comment. We are opening up for questions now. Let me start with the committee members, give them the first tab, but then we will also allow for our guests in the room and on the Zoom to ask questions of Heidi now as well, because this data, I mean, it's very clearly presented. It's also very sobering. So want to make sure that we have time for folks to ask questions and probe a little bit as needed. Let me start with the committee. Any questions from the committee?
Go ahead.
I was curious about data for non-fatal overdoses. You know, what are the rates looking like? Is that part of the dashboard? You know, what we're seeing in terms of trends? Are we getting ahead of, you know, some of those potential issues? Where can I look to find that information?
Yeah, absolutely. That is a great question. And I know you may not be in the chat. The Overdose Surveillance Data Hub does have data on both fatal and non-fatal overdoses. So rates can be found there. I think, I'm not sure if there's a short link or if anyone has access to the PowerPoint, but it is also linked in the PowerPoint as well.
Thank you.
If you look on page 33, you can find.
Yep, I see that here. Yep.
Brandon.
Thanks so much, Heidi, for that presentation. This is Brandon. I think the heat maps will be really helpful so we can watch for those. Do you have any sense about some of the geographic variation overdose rates or town level information that you can provide at this time?
Yeah, absolutely. So I think as expected, Our most impacted regions, at least by count level right now, are our, frequent Providence, Pawtucket, Woonsocket. Those would be probably the top 3. And my plan moving forward is to also look at the impact among different race and ethnicity groups and see if that changes at all. But that is absolutely something that we hope to be getting out soon. I know that a lot of people use that for outreach as well.
Any other questions from the committee? Okay, how about questions from,
I have one question. I don't know if this data is captured by Rhode, but do you guys measure the time, like after, say, release from the ACI or after discharge from a hospital or a treatment center to overdose?
Yeah, that is a great question. So that information is not captured by the Office of the State Medical Examiner dataset. However, we do have an additional fatal overdose dataset called the State Unintentional Drug Overdose Reporting System. And that will give us a lot more detailed information about other circumstances, such as were they recently released from any sort of institution, be it a treatment facility, a detention center, rehabilitation, anything like that. Unfortunately, the timeline for receiving year-end data is a little bit behind. We have to submit it to CDC and get it back. So full 2022 data should be available to us in a few weeks. But once that does come to us, we plan to look into other more detailed variables such as that and share it. So I think that's a great question.
Rachel?
The upward climb in the rates among Hispanic and Latino populations is very concerning, of course, and I was wondering if there's an opportunity to do a deeper dive into the specifics of that population and demographics within that sort of thing to try and get a better understanding of what kind of engagement or actions might help slow that.
Yes, yeah. And actually that is what I've started doing this week, is looking into that, just because that change in rates was so drastic in this past year. So we do plan to look at, where the overdoses are occurring, age categories, gender, what substances were involved, and break that down by race and ethnicity to see if there were any changes or other, trends that we may need to be paying attention to in that regard.
Yeah, Heidi, the question I had is there any explanation that you have or anyone has about why July and August had such a statistically significant drop in overdose deaths in previous years?
I currently do not have an answer for that. And I think that's something that we want to look into in the future, especially knowing that almost every month in the first 6 months had an increase, and then that drastically changed for the second half of the year. So I know I do have plans to meet with our prevention team and other members on my team to see, were there any initiatives that were happening? Was there anything else going on in the community that might have impacted this? Were the populations different? So unfortunately, I don't have an answer today, but that is something that I would like to look into.
Yeah, in my opinion, it'd be something to look into, because if you kept going with the statistics and kept extrapolating that onward, you probably would have reached your prediction, or the agency's prediction, a projection of 492 deaths.
Mm-hmm.
Drop was very significant compared to, especially the month of August. You look at almost a 14-point drop. So it's like, it'd be interesting to see what happened in those 2 months, and if it was something good, how we could capitalize that in future months to utilize. Was it casework? Was it people on the ground, grassroots efforts? I don't know. I mean, it was legislative efforts that took place that we implemented in those first fiscal year, and I don't know. I don't have the answer. It'd be just interesting to tease out.
Yeah, absolutely. And I will say, I think any successes in, reduced numbers of fatal overdoses, a lot of credit does have to go to the peer outreach teams. As far as specific initiatives, I don't know. And I think that's something that we plan to look into, you know, what in those specific months was happening.
And just one final point, maybe my friend here from the epidemiology world can help me. The data, unfortunately, is starting to mirror a little bit of the suicide data, where you have people 55 or older being the highest group, and that's what we see with suicide. The older you get, the most risk you get. And we'll also see in Hispanic and Latino group, and we see that with Hispanic, Latinos, and whites having the highest suicide rate. So, and we also see that, I know a very good study was done by Dr. Spiro around the hospital looking at adolescents, not the same group though, that we also find that suicides occur mostly in a person's home with adolescents, in their home that they live in. And we see that here, that 84% of overdoses occurred in private settings. So there's a little bit of mirroring taking place here that we should look at among that and see what some of the factors are. That's just my hunch.
Yeah, absolutely.
Any other,
I just wanted to, I can tell you a little bit, Heidi said a little bit about the hypothesis. We can't actually give, you know, I don't have a statistical causation to this, but just from my work at the Department of Health on the mobile outreach teams, as well as the work with the HDH's outreach teams, one of the things that I can say is that there was an increase in the mobile outreach teams and the work that they were doing, boots on the ground. In addition to that, there was also an investment made in the harm reduction toolkit, which increased the availability or the easier access to fentanyl test strips and safer smoking kits. And I also want to just say out loud, you know, that the peer organizations that are really boots on the ground and they're doing this amazing work, both VHTH and the Department of Health. I mean, I just want to really say that if it wasn't for them, these numbers would have been much, much higher. So that's just something to think about. And I also believe, don't quote me on it, I believe that there was also an increase in with some of the mobile treatment and access to treatment during that period of time. But that's just a hypothesis because I can't confirm that. But I think that it was a multitude of really working together and an increased coordination across the board on all of these efforts. And again, I really want to just say that to the peer organizations that are out there, boots on the ground, really trying to go out there and save lives. I mean, I wish nobody, I mean, this is my community, I'm a person in recovery, I wish not one death, it was never a death again. But at the same time, I think that it's really important to highlight the amazing work that they're doing. And it's really important that we continue to look at the Latino and the disparities in our BIPOC communities. I think that's really important that we continue to highlight that.
any other burning questions for Heidi? Because we're gonna need to move soon. Bob?
Just a quick one. I'm fascinated by the correlation between alcohol and the opioids in terms of synergy and how much emphasis alcohol is such a commonly advertised drug, the impact of the synergy and how much emphasis should we be putting on as a committee here as some of the contributing substances that synergistically work with alcohol. To see these numbers, and I think sometimes there are a lot of people who make decisions about going out who might be on a pain medication, who are not aware of the synergistic effect. And I just didn't know how people felt about, you know, the role alcohol plays in all of this.
Other questions, and I'm opening this up to the guests, visitors as well. Any other questions for Heidi while we have her? Yes.
I have a question about the xylazine. Is there on the horizon or close any good testing, not toxicology testing or urine testing or blood testing, but testing of a product that is pretty valid yet? I believe I heard from the HDH that there's 2 tests out there now, but they are, you know, they're not 100%. You have false negatives, false positives, whatever. So is there a movement around that?
Do you want to
Heidi,
have your account or Heidi?
Heidi, do you want to, or should we pass it to a member of the committee? Did you hear the question?
I kind of heard it. Was it just about toxicology testing for xylazine being available? Is that? generally.
Test strips?
Yeah, I think Linda's asking not so much toxicology testing like laboratory testing, but consumer-based product testing.
Yeah, I don't know that I would be super qualified to answer about the consumer testing if someone else wants to grab that.
I can take that one, Linda. So test strips for xylazine are available from at least one company, BTNX, which manufactures the fentanyl test strips. There's a team at Miriam Hospital that's validating them right now to make sure that they're accurate. There's a few studies very early up from Pennsylvania that says that they do a great job at identifying xylazine. And I know there's been a lot of discussions with Kathy's team and with the health department to start distributing those as soon as we know a little bit more about their accuracy. I think that should be coming soon, is my understanding, Kathy, that information, but I can check with Tracy.
Yeah, check.
I'll check with Tracy. Yeah.
Hey, Brandon, it's Rachel Whiteman on Zoom. I just wanted to add to that. In the analysis that they've done on those test strips, the xylazine ones, they're only recommending them for opioids right now and not for stimulants. If you look at the most recent CSFRE evaluation, that's their recommendation. And on the BTNX package insert, they're also recommending that because of high cross-reactivity with lidocaine, because xylazine and lidocaine actually share a metabolite. And so unfortunately, lidocaine's a very frequent cut in drug samples. And so they're seeing that especially in stimulant samples. And so actually not recommending for use with stimulants right now. Hopefully that will change over time. The other thing that I would say is that there are a bunch of commercial labs that are developing xylazine testing for urine tests. And right now at Rhode Island Hospital, we have it as part of the LC-QTOF MS comprehensive screens. You can at Rhode Island Hospital either send samples there throughout the lifespan system to get xylazine qualitative results right now. And they're working to build a quant.
Thank you, Rachel. Okay, and thank you, Heidi. We're going to move on now. Appreciate you making this presentation to the OSAC. And Heidi's contact information is in the slides if folks have follow-up questions for her directly. Okay, also in preparation for our decision-making recommendation process for FY25, I have asked the EOHHS team to try to pull together in a easy to follow format, no small task, a status report on where we are with the FY23 spend and FY24 to compare our allocations to what has actually been contracted or encumbered. And they did that. They took on that task. And so Marty's going to come and present an update in a slightly different format than you're used to seeing it. But I'd love your feedback, committee members. I think it's a very helpful format. So I just want to thank the team for putting this together and allow Marty to come up.
I think sit, because it's kind of a lot. So, I wanted to say one thing first, and just to share just for a moment, that Lauren Nocera is really sorry that he could not speak with you all individually or tell you himself, but he had a personal issue and needed to resign. And, you know, it is, we wish him the very, very best. We had time though, before he left to do some planning. We were prepared for all of the major pieces of work that he helped us prepare before he left. And I just personally want to say how wonderful it was to work with him. He was amazing at his job. It was, you know, it was a great partnership, and he is, you know, it is too bad that this happened, and we wish him the very best. And so I wanted to thank him out loud from certainly our team's perspective. All right, so having the task to present the year-end information to you, we thought that a Gantt chart might be helpful. And what we want to reflect here, what we thought would be helpful to you is, you know, we got this big bolus of money at the beginning of FY '22. So everything here is the fiscal year. When I use a number, it's the fiscal year, July to June. And it took time. You all didn't sit till August. And we didn't, know what we were doing until then. And then we had to do all the procurement. We know all of that. So what's interesting about this, though, is the reality that what you allocated in FY '23, as you're going to see, is going to be spent a heck of a lot in FY '24. So as we are thinking about FY '24, those dollars will add on in FY '24, and they are likely to go to FY '25, which means that your FY '25 dollars may well start at FY '25 but go to FY '26. We know we want it to go faster. I have some interesting news about that at the end. I'll end with the fun news. But the reality is that contracts, are for a year or sometimes more. And so you're ahead of the game a little bit. You're ahead of yourselves. You're ahead of the time in terms of allocations. And this is going to help you see that. So we're going to use the same order as we've been using in our presentation, and I'm going to draw you through it. Committee members, you have this document, and we tried to cut and paste it onto these slides. And I would ask you to use this Gantt chart document along with this Word document, which unfortunately, folks on Zoom, you don't have, but we will make public after this meeting, and they go together. So in the first, let's talk social determinants of health. You will see that the very first one, the first responder and peer recovery trauma supports, as we shared with you, is difficult and complicated. We're still in procurement planning. We're estimating that we could start in Q3 of 2024, and a one-year contract would get us into 2025. You can see the yellow is still in procurement planning. The green and blue, the green is either spending or close to spending, like procurements are in process about to be finished, and a one-year contract. The blue that you'll see on here easily, and we'll show you in a slide soon, means that it's more than a one-year contract. We were able to, for a variety of reasons, what the vendor wanted, what made sense, to do a longer contract. So those will, on purpose, stretch into the next fiscal year. So, and how the documents work together, you'll see the basic needs provision for high-risk clients. We've told you before that these are 14 contracts between BHDDH and Rhode. Couldn't fit it all on the Gantt chart, but the list of the 14 contracts are in this document. So between the two of them, you have here all of the projects, the agency that is overseeing their procurement, the vendors either listed on the Gantt chart if there were one or two and we had room, or listed on the Word document, matched up, the amount allocated, the amount spent so far, the amount remaining, and the general time period of their contracts. And this is for only for FY '23 money. So you can see here, I'll go in some depth. I'll give you the highlights as I would usually do. Recovery housing, BHDDH with mammoth work has done an initial procurement, and for a variety of reasons, the applicants applied for $100,000 worth, which leaves $650,000 of the $750 that was initially allocated by you. They think that they can get this going in 2024, in FY '24, maybe Q3 or Q3. And so we have shown you here what we're spending. We know we're spending. And then that, as we talked last time, remember about, there being money to continue to be spent. The feeling is that we should continue to invest in recovery housing, that they should go back and do procurements. We don't want to take this away. This money would stay in the recovery housing pot, continue to be procured by BHDDH. In the housing, the other types of housing, we are excited that we are supporting. This is procurements that are happening now. Medical respite for folks who are people who use drugs, who are having illnesses of some sort, have been homeless. This is a place for them to be while they are ill, to get better and hopefully then get placed in housing. A particular, the first line is a 6-month contract that was really critical to make this medical respite work. And then that second line is what we were able to be creative about for wound care, mobile medical respite. We know we had the presentations on xylazine and the terrible impact it has on wounds. And this will be mobile medical services for people with xylazine-related wounds. And serving them in the community. James Rhode is here and can answer any particular questions that folks have on this. And then the rest of the housing is still in procurement planning. There's just under $1 million, and we look for that. It's happening. James is the master of all of the housing work, and we believe by around Q2 of FY24, this should be in play. This is graded funding, all with the Department of Housing. It's complicated, and I'm grateful to James for all of the work that he does, and I do not have those details. That is our social determinants of health. I don't know that we have time for us to go through every single one of these at this depth, but let me move to harm reduction and make a couple of comments. Newly set here on the alternative post-overdose engagement. Safe Landings is a project that BHDDH has been working hard on. They are very close to procurement completion. There'll be around 350,000 spent. And actually, I see that I should have made that over 2 years. This is new. I'll fix it for when we post it. There's a lot of details here. We tried to get as many as we could, right? But that's going to be a blue line, and that's going to go for 2 years. And then there's going to be an investment in the community overdose engagement, the code investments, which also focus on post-overdose engagement. And there are 3 contracts, the details of which are in the Word document. Other new things here, the new outreach focused on BIPOC communities. There was a breakthrough in the procurement. They are all in negotiation now. Those will likely start by Q2 of 24. And obviously with the numbers in the Latino community, more important than absolutely ever. Moving on to treatment funding. This is great news. Kudos to BHDDH. Investments in Zinnia Health and Bridgemark Addiction Recovery Services. These are infrastructure dollars for new residential treatment that will lead to 44 new residential treatment beds. Your work, your direction to us is going to lead to 44 beds, which when you add to the stewardship dollars that are being invested in Galilee, it's a total of 58 beds that will add to our residential treatment capacity. So this is big news. Everything else on here you had known about. Recovery capital. New procurements also at BHDDH. They've been very busy. 4 contracts with the recovery community centers for $200,000. This is remember you agreed to and told us to support things like gym memberships and transportation to help people in recovery, add to their recovery capital. And this was new. I don't believe that we were sharing this. There's $250,000 in that pot that will remain in procurement planning. We have other ideas about that. The recovery centers could only really handle the 50,000 each, but we have some other ideas. We're not proposing to move that out of recovery capital. We're going to keep procuring that. On the prevention, some new things here. Prevent Overdose RI. If you need information on data and you're either going to go to the Department of Health or you're going to go to Prevent Overdose RI, and the dollars that supported them in the past have been cut. There's a cut to a federal grant. We felt that in the communications realm that it was very important to keep that crucial connector funded, and so our communications team is going to work with them, and that's going to go $300,000 over 2 years Again, FY '23 dollars, but being spent into the future when they're needed to be spent. And that's the new things there. On governance, offers are in process for our evaluation team finally. So we're excited about that. We expect them to come on soon in July. We have a proposal when Carrie gets to the race equity work. We think that in the evaluation work, since we didn't spend all of the dollars in FY '23, that it may make sense for you all to consider spending some more on that race equity strategic planning. We don't have a particular proposal right now, but we think that one may come out of the discussion that you're about to have this afternoon. And then the CPR training for providers with a focus on the xylazine approach, Substance Use and Mental Health Leadership Council. And that, I want to go back and I want to address what you probably are looking at, which is that the amount spent is not, that it's much less than the amount allocated. Again, contracts begin, organizations need to get going, need to start billing, and sometimes the plan is a ramp up. And so we are monitoring this. This does not include June invoices and there were some places where we had some estimates, but we generally didn't include the estimates. We're waiting for actuals. And so this is going to grow every month. We can see, and Michelle Goncalo is here from our finance team, it was very low and it started to grow month by month. The agencies are starting to spend and we're starting to see the invoices, but we get our June invoices generally by July 6th because they have to get it in to get that end of year time period. And so we'll be able to continue this this format, if you like it. We propose this to be the format for the transparency portal that we're expecting to put up. If this works for you, if you have comments on it, I don't know that we need to do that here, but you certainly get in touch with me, tell me what would be more helpful. There is more data, it was just only what could fit on the paper that we shared here. So happy to take questions.
I think it looks great. The question for you, do we know how we compare to other states in terms of spend?
That is a cool thing. Let me share.
We're leaders.
We are leaders. We are going to announce very soon, it's going to be announced that we have won an award from the Johns Hopkins. There's a coalition that Johns Hopkins, which did the principles. They have awarded us the Excellence in the Application of the Opioid Litigation Principles Award. It's a national coalition. And we and North Carolina won this quarter. Last quarter, it was Colorado and another state that I can't remember. And we're one of the top. They're telling us that hardly anybody is spending as much as we are or providing this level of information.
That's great. And in terms of municipalities, I know it's a different realm, but any idea what the spend is there?
Don't have the spend, but as Carrie shared with you in her email last week, the amounts that are allocated are now up on our website. It's a little bit hard to find. So she sent you the link and the exact page, like it's page 3 of this particular link. But at least the amounts that the municipalities have received are up on the website. And we can continue to work with the League of Cities and Towns. I don't know, Adi, if you have any other.
Yeah, look, I think it's worth engaging with the League of Cities and Towns, and starting with perhaps creating a platform. We have such a great platform on the UHHS website, for reporting, and perhaps there are municipal representatives, obviously, in this committee, and that's something I need to take back regarding, having a reporting mechanism where cities and towns can report what they're spending, and maybe UHHS can
We can aggregate it.
aggregate it and present it on the website. You can see, presumably they're reporting to their own constituents a variety of these publicly spent dollars, but that I think is
could be a really, well done way of doing it, but, I think we should continue to discuss and talk, and I heard Senator Miller's comment about some additional potential measures that could be brought to bear. I'm not gonna address that, but I want to just, I do think this is really good work. One of the things that I was kind of thinking about takes some time to process sometimes. So this is like the data processing going on with some of what you're talking about. I think that one of the things that we may want to look at as we're looking ahead, fiscal year 25 and maybe next and beyond, is for one thing, I don't feel like, I personally don't have this great view. We don't have the MAP is going, the EOC, now that there's some changes in representation on the committee. And I'd be interested in hearing about that. And I'd be interested in looking at ways that probation and parole can be leveraged to help bring people, connect people to treatment, and ensuring that transition happens. But, I think this combined with the data that we're getting from Rhode, I think can really be useful to inform some of our decision making.
Any other questions from the committee? And I'll send to them.
So, I don't want to sound like a broken record on this, but I think if we were at 90 days, we'd be really happy, right? But it's just not possible in government on the time when advisory decided that or agreed upon spending. And then we got it out the door, especially in the realm that we're dealing with. And so just looking at that and trying to pinpoint where it goes longer and what creates delay. And I think that, well, you can tell me, and because I'm interested in trying to help making the time span smaller. Is it designing an RFP that's very complicated and presenting that RFP to DOA? Is it DOA in their ability to procure once it's in their hands? Is it a provider not being staffed up or trying to get staffed up or trying to get something contracted like in Zinnia's case and actually having contractors build space or just, a year into this, and you don't have to answer all this right now, but a year into this, where do you see the biggest concern about how long it takes for money to be spent?
Honestly, I think it's all of that together.
Yeah.
There were some things that, so it's a good time. I am a big fan of like an evaluation of what's working, what's not working. So
right.
What really worked were the things that were contract modifications. People were doing things that you wanted to make them do more of. And we were able to put those dollars to use pretty quickly. I can tell you, for example, with the first responder peer recovery trauma supports, it was hard. It was hard to figure out how we were going to make it work. And, with everybody working on all of the other components, like to do the things that were easy, but still took a lot of time. We just didn't have the time to, another set of hands, another brain to figure all of that out. And the fact that the state folks have to do the procurement, that we can't say, come in and hey, do this procurement, because it just puts you at risk for not being able to, like the real subject matter experts can't really help us because they can't talk to us about it. So I think all of that contributed. And then, we have to give at least 4 or 5 weeks for entities to write the RFPs. The RFPs are not easy to write. They're complicated, and we're asking for, we're asking for a lot. We're asking for new data. We're asking for equity considerations and how this is going to address disparity. So it's not like simple RFPs that you could write in an afternoon. And then the negotiations, they take time, like lawyers get, with no disrespect to any of the lawyers in the room, but, you know, we have complicated contracts and they have to read them. The partnership with the Rhode Island Foundation was beneficial in many ways. The grant making that they do and their sort of grant making administrative functions were quite helpful. And we're going to meet with them and talk about what possibilities there are. But I can tell you that we got faster. We always get faster. Like we always figure out, oh, let's not do that again. But it is all of those things. When we know exactly what we want to do and we have a mechanism, we got that down. Some of the things that you suggested that we do and that were inputs from the task force were just harder to think about. You know, the safe landings, it took time to figure it out. The family supports, I know we really want to do the family supports, it's taking time to figure that out. But what's good is that all of these things that are done now leave us more time. And now we can take all of the things that are yellow here, which are the ones that are not yet, and like that's our summer job, like figure out the yellow and figure out the FY24. And a lot of the FY24 that you have allocated, more of it is sustainability, and so it's going to be easier to figure that out as well. We will get faster.
One thing in response to that, one thing I will be continuing to advocating for, and I've made it clear to those who are directly involved as we go through the advice and consent process as a senator, is that there doesn't seem to be a difference within DOA and how fast they can process a procurement, whether it's a life at risk or how fast you can lay blacktop on a road. And it seems to be the same process. And to me, it should be a different process when the life is at risk versus laying blacktop on a road. And there should be an expedited process where there's a life at risk.
They have, I think that they may be hearing you. I think they're adding one more staff person and they're doing some other things, but I'll just leave it at that.
We will never have another year of settlement funds to be spent. I don't anticipate that we will ever have another year of settlement funds to be spent where we have as many new procurements as we did for FY23.
Yeah.
So I don't want to minimize things. So, you know, Marty was like, oh, so now we just have to do the yellow and FY24. I mean, that's a lot still. That's a lot, but it will only get better from here. Brandon.
To Joe's point, I think Marty is being humble. You know, many states have not even started this process.
Right.
And Reuters reported that only 10 have actually started spending at all. So we're probably well ahead of those 10. Vermont just left 7 million. They couldn't figure out how to spend 7 million. And, you know, so we also decided to allocate all the funding, which I think is something. Other states and got halfway through a fiscal year and then just left a big chunk unallocated. Yeah, so just to reflect, like, you know, we should always try harder and be more efficient and faster, but compared to other states, we're really doing an incredible job. So thank you all for your many efforts in this. I did have one question, just around, remind me again where the xylazine pieces are fitting. So there's the wound care piece
and
then
housing.
is there one more?
The
Marty, that I might have
CPR, the
missed?
CPR.
Yes, okay, and that's the sort of xylazine specific programming
For right now.
currently, right now, okay, thank you.
Let me, oh, Adi.
Yeah, I just want to follow up on Senator Miller's point and Marty's point, which is, look, I do think it's really important to keep on the lookout on where the bottlenecks are and to try to leverage, whether it's the Rhode Island Foundation, the United Way, partners that can be, maybe we have to provide them with very clear guidance and they have to provide us with very transparent reporting on how this is getting allocated, but maybe able to move things a little bit more quickly and flexibly. I think that's definitely something to leverage. And then Marty, I mean, it's good to hear that the DOA is putting in some like maybe more dedicated resources to just this project, just like EOHHS has put dedicated resources to manage all of this, which I think is essential. And you know, there's no reason why
maybe that procurement can't, you know, I don't know, it just maybe needs to be dedicated to this.
So we're finding, I mean, every agency, I'm just gonna say, could really use more resources to do it. And we've done this for your suggestion of at very little, with very little, but you heard what I said about BHDDH and Rhode. They did all the work like in the beginning, and I just didn't talk about the Rhode ones because they were procured already, and Rhode has done amazing work. So it could take more people. If we had more people to do it, it would go faster.
Yeah.
So it is something for us to consider. We need to bring that back to you, and I think that we will as we look forward. We're struggling. Our folks are struggling. BHDDH is struggling. Rhode is struggling to do this within like a 10-hour work day, a 50-hour work week. So, you know.
I keep trying to open a public comment, and the committee keeps having questions. Rachel, please.
I was just gonna add on to that, as somebody working in municipalities who also has to go through public procurement and all that. And also is now charged with our municipal settlement funds in addition to ARPA funds and other things. I'm very sensitive to that. With more funds, you need more people and more infrastructure to operate the funds. And I think that piece is often just omitted. So I definitely I just support from my own experience, any increasing of the infrastructure of those humans that are actually doing the work, I think is super important to be built into the use of the funds itself.
Yes, we have a sense of urgency when government came into the state of Rhode based on the crisis that we were through, the opioid crisis. And that at some point make us to expedite the process and probably leave lingering some of the angle that we have to take into consideration in order to really do it well. It is always room to grow. And I think we're gonna learn from that things as a married. We have to be proud that we have accomplished so far because we have monies on the street, which is doing good things, we're saving life. And so far, we are doing well. So I know that it's always room to grow. And I know we're gonna learn from our mistakes in the first phase of this distribution, but I guess that we were trying for that. So we're doing good and we need more, always, trying to put things in place, a good system in place, but I guess that so far so good.
There are a couple of questions in the chat. One was answered about the quarters, fiscal year. So quarter one is July through September and like that. And Jonathan had a comment. I think, Jonathan, you were thinking that BHDDH would provide funding. No, the idea is that there would be another procurement through BHDDH to a community organization for that $250,000. We were not saying that, here, I'll find it. We're not saying that BHDDH would spend the money on the services themselves, but here would procure it to the community. I hope that answers your question.
Let's formally move into public comment, and I'll invite folks to introduce yourselves and offer public comment at this time, not 1 to 2 minutes per person, please, both on the Zoom and in the room.
Hi, just Catherine with Integrated Healthcare Solutions. Just to offer some real world feedback to kind of go along with all of today's, sobering data that was shown up front makes my heart race from where I sit from 15 years ago when my brother sick over this. And those numbers, 434, we really need to multiply those by at least 10, because at least 10 people for every one person that's lost is impacted. And we and our organization specifically do help with grief, holistic grief programs. And I can tell you the real world crying, everyone deaf, these people that are in these programs and the people that are in our organization, this is like their 5th death. their mother, their aunt, their cousin, their friend, their other friend, this friend, I found my best friend did. You know, we had a mom come in recently whose son for 10 years struggled with mental health, ended up in Butler, came out of Butler 3 days later, committed suicide. So she's living with all that pain and suffering, but also her present son is sitting in the basement smoking crack. She had to call him to the ACI. So, you know, just from a funding perspective, you know, grief, and I know when we get to 2024 and beyond, but grief there needs to be funding to sustain this. And just the other comment about funding is, you know, as a small nonprofit in this, I mean, we're a state of money, but it feels like we have no money. You know, to do the little pilots is great. You can produce the greatest program in the world, but I just had a call with a woman last night who's like, you know, it's not sustainable. And so when they're sitting there hanging on by a thread, and I said, oh, I have a free thing for one night, but there's nothing that continues because, right, people are hanging on by a thread. So the 434 we focus on, but how many people are hanging on by a thread right now? And that, to the point, everyone in the state needs help holistically with their body, mind, and spirit. And this has to be a piece. If you don't address this in the funding and put significant funds that are gonna make this sustainable, we'll never get ahead. Those numbers will never, ever, you know, go to where we really want them. And then the prevention piece and the doctors and the prescription meds. I mean, I have 36-year-old women I'm working with who are on like 13 medications. So this has to be addressed beyond just the illicit medication. So I've lived the addiction, I've lived the death, and I'm 15 years old. These people are in the midst every day living this, and the pain and suffering that they have squished inside of them, they need the holistic support, not just more medication, more therapy, it's just not enough, it's not. So, thank you, I know you're working as fast as you can, but please continue, and it's so needed. And what Senator Miller keeps saying is these people are desperate.
Other comments?
Okay, I want to follow up on this. One thing you said, Catherine, struck a chord with me. You know, obviously at the when I was at the U.S. Attorney's Office and at the Attorney General's office now, when we work on violence prevention, there are a lot of techniques and strategies that are being used in that field in terms of mapping. We try to map locations where violence happens and individuals who perpetrate that violence, and then look at their associates and associations and the kind of certain predictions and patterns that you can take a look at and see where you need to target your efforts in terms of preventing future violence. How many conceiving the violence drivers are. And, you know, and again, I imagine based on some of the stuff that Catherine talked about, is that some of this work can potentially apply to this area as well. You know, are there individuals who are involved in overdoses, and they can, you know, can we then take a look at those around them? And how many of them, and this is just, I mean, if you're an epidemiologist, that's kind of like everything you're doing, but like, right, like who are around them, can you make any predictions of where you need to focus your efforts in terms of associates, family members, friends, to target your prevention efforts in a more targeted way, based on this mapping. I know we do mapping geographically in heat maps, but this is a little bit more individual. And so we're just kind of like reacting to that.
And we heard some of that in the data presentation as well, the work that the health department is looking to do around kind of heat mapping, but yes, I think there are folks doing that work. And that kind of social epidemiologic response. Okay, not seeing, I think there's none in the chat, not seeing any other hands for public comment. I'm going to keep us moving. Thank you, Marty. Thank you. I really appreciate this new format to present the status of the procurements. Okay, I'm now gonna ask Kathy to come up because, as I mentioned at the top of the hour, this group certainly knows, we really value the input from the governor's overdose task force. A little tricky, right? Value the input from the governor's overdose task force. We're gonna have formal recommendations from the task force work groups for our next meeting, but we have some initial recommendations, feedback from the breakouts that happened at the last task force meeting. So I'm gonna ask Kathy to kind of go through that briefly to give you a preview. Well, it's not a preview, it's an actual view.
I'm gonna sit just because my feet are starting to hurt, because we did a lot of running around and I took my sneakers off, if that's okay with everybody. We can go to the next slide. So I just want to remind everybody of the task force strategies. The task force strategies, I know it says it's task force strategies, but this is the biggest community convening meeting in the state. And this was a very comprehensive strategic refresh that was conducted with multi-stakeholders. So when I say community, I mean treatment providers, our state agencies, it's law enforcement, it is the entire state as far as we could reach in one public setting, which is, we're looking at about 200 people that are showing up on a monthly basis, about 150 to 200 people. And also the 9 work groups that are associated with the governor's task force. So I just want to remind you all of that, that this is much more than just the task force. This is the state. We have state representation. We have community members, people with lived experience, family members. We have the holistic approach and we're looking at all the 4 pillars. So I just wanted to kind of remind everybody of that. And the goal is to, to end the overdose crisis, to ensure racial equity is embedded across all pillars, not just conversations, to actually take some action towards addressing racial inequities as well as ethnic disproportionately impacted groups of people, like we saw, in the data for our Latino community. And then improve lives and uplift community voice. I think everybody knows I'm a person with lived experience. I'm directly impacted myself personally with the criminal justice system, with treatment access, all of those the things. But it was many years ago, and things are different now. As well as everybody else who's been impacted, communities and family members. The use of data to drive change. We just saw some data, and there's many other data sets that are presented within the task force work groups, within the task force also here, as you can see, and also on the Prevent Overdose RI website. We're so happy to partner with our teams at Brown and our other state agencies on that. And then build community connections to care. And then again, the task force, or in the state and myself and the community, we're committed to addressing the root causes of overdose, including the socioeconomic factors that influence health. And I think we were kind of talking about that when I heard mapping. When you think about mapping, it's all of the stuff that is impacting the state. So some of the feedback, these are just the 7 different work groups that the breakout sessions that occurred, and many of you were participants in that, and I want to thank you all for attending and joining in the conversations. And so I'm just going to go over the key takeaways. I do talk fast, so tell me to slow down, but you can read them behind me. I don't know if I'm in everybody's view, but some of the key takeaways in some of the breakout sessions were racial equity, and continue to address racial inequities across the continuum. Invest in stimulant use treatment with safe housing options, and sustain racial equity work, continue to fund the racial equity strategic planning, and to fulfill the commitment by all work groups in the task force to adopt recommendations and strategies that embedded racial equity in all its work. Emerging issues, this is really important. We've heard this here, and we've also heard this in many of our work groups, as well as the task force and in the community and stakeholders, is just having, being able to pivot very quickly when we see these emerging issues. Xylazine is an example. Drug supply continues to evolve, increase sustained drug testing, add portable options in mobile vans was one of the suggestions, and address wound care needs, including education around xylazine and outreach by wound care specialists. And as you saw from some of what Marty presented earlier, that is something that we're beginning and completely committed to, based on the feedback that we've gotten. Social determinants of health, always thinking about the root causes, safe, affordable housing for all. I'm gonna read this, verbatim because this was very specific. Review and conduct cost benefit analysis of housing first practices, the use of emergency departments, recidivism into or out of the ACI residential treatment. We kind of heard a lot of conversation about the DOC and how we can target that population. Increase housing stabilization providers that can deliver housing stabilization services. This is Medicaid reimbursable. Invest in alternative housing for people who have a reoccurrence. Harm reduction focused housing. So this is like that option of maybe people don't want to go into recovery or be abstinent based, and having those options for folks so that they have a roof over their head and they can start to increase their quality of life. Invest in incentives for landlords, recovery housing, house owners, subsidies to ensure safe, low barrier housing is available for all. Again, focusing on all, meeting people where they're at. Increase access to oral health, both preventive care and reconstruction. You saw the presentation for oral health last month here in the opioid settlement committee. And provide care packages for people new in recovery housing or apartments, food, furnishings, and toiletries. We know that we invested some basic needs funds. You saw that with Marty, but like thinking about like when somebody walks into a recovery house, I can tell you from experience, when you walk in and you just have a bag of stuff and you just got released from the ACI, true story too, and you don't have any food, it creates a barrier. And many times people will probably leave recovery housing, either for shame for not having food, or it could be they could be discharged or get in a fight because they take a granola bar from somebody. So those kind of things, or somebody who just got into an apartment and they don't have a bed. Like those are the kinds of things that suggestion was. Communication, focused, targeted media campaigns for specific populations, pregnant women, adolescents, invest in prevention education and communications that address stigma, racial inequities, overdose addiction and strategies. Prevention, continue to invest and expand student assistant counseling, increase drug take back, increase focus on children exposed to trauma, increase after-school mentorship, leadership and development, address anxiety disorders, and discuss the impact of adult use cannabis. That really is kind of, if you look at the strategies, it's exactly what is in the strategies still. Harm reduction and rescue. Sustain and invest, increase investment in the harm reduction infrastructure. We talked about some of the hypothesis of why our numbers kind of plateaued, and these are just some of the things that I said earlier, and that's sustaining the naloxone, sustain and increase harm reduction toolkit, continue to support the overdose prevention center, sustain needle exchange, continue to place the 24/7 access to harm reduction tools, including the vending machines that are at the ACI. I don't know if we've had that discussion here, but that is actually a true story that, right here behind us in women's security, I believe there is a vending machine. And sustain targeted data-informed mobile outreach projects. And treatment, improve racial equity in treatment, expand faith-based community through Armani and other outreach efforts, sustain outreach and treatment for BIPOC workers, increase treatment workforce diversity, cultural competency. I would say, and I always say this, is that we should definitely make sure that the messenger or the treatment provider looks like the folks that they are providing services to. So that's something that's very important. We hear that in the recovery as well. I may read it off, but we hear that a lot in recovery and harm reduction as well. Expand education, decrease stigma in the treatment settings. Support more education and research around xylazine, increase training in addiction medicine, fellowships, and improve coordination and education to primary care offices and providers. That is something I've been hearing for many, many years. I'm sure we are doing work on it, but it's constantly said. So that's very, very important that we continue to educate and have better coordination and understanding with our providers, our primary care providers and our treatment providers. And then recovery, increase investment in recovery, including support for workforce and recovery capital for members, ensure recovery housing sustainability, That's very important, even though it's here in the recovery, it's talked about a lot in the social determinants of health. It's absolutely essential that people have a safe place to live. Address workforce traumas and burnout, provide additional workforce supports, certified peer recovery specialist trainings, trauma-informed supports and supervisor trainings, basically investing in our workforce. And support continuously updated resource hub across all pillars to ensure available options are shared with programs and the people that are using them. This was talked about in both treatment and the recovery work groups, and it is one of the most popular of all things that are talked about, is to just have a hub with updated resources that would need to be monitored and continuously updated, and also vetted by people who have used those services. Policy support bold policy changes, advocate for policy changes, decriminalization, housing shortages, pilot safe supply, best practices used successfully in other countries. And I know that was a lot of information. You do have it in your slides, but I do want to end with this, is that almost all of what was said in these breakout sessions was also what we heard when we were doing the strategic refresh. And remember, the strategic refresh does include the investments that are made of the opioid settlement committee. So I want to thank you all for continuing to move forward and make the types of decisions that you're making and or recommendations, and continuing to support the community and all of our stakeholders. And that's it. Thank you.
Thank you, Kathy. Do the committee members have questions of Kathy? Yes.
So in the key takeaways, what I don't see, and I wondered if this was part of the conversation, and this goes to how we prioritize, I think, and how we prioritize is represented in how we decided on the spend in the first round of this, right? It's the impact each initiative can have. And was there talk in the key takeaway based on geography or another demographic? Like, it's really bad in this neighborhood in Providence, or it's really bad in Woonsocket, or it's really bad in Latino community. We need to spend where will have the most impact to that community. Or it's, we have to do something if 85% of fatalities happen in a private setting. How do we get more of those people to more of those people where it's happening in a private setting? Was there that type of conversation?
So I have a very detailed, this is pulling out the key and kind of broadening it, but there was, I can remember off the top of my head, there was mention specifically of Woonsocket and issues around food and needing to have more food in Woonsocket. There were also private settings is always kind of talked about. This is the key takeaways of the breakout sessions, but the actual recommendations that are going to come to the opioid settlement committee do mention for sure the private locations and families and so on and so forth. I only remember seeing mostly once, I saw Woonsocket, but I would have to.
I just brought that up as an example. But when I always looked it through at the lens of having impact, should the impact be like by demographic, or should the impact be also looked at by geography?
I wonder if it should be both.
Or both, or, you know, not only initiative, but where the initiative would be most important to have the most impact.
I think that the data, using data to drive action as an overall strategy, I think it's the key with that. So I totally just agree with you. I think it's both.
Other questions for Kathy?
And then the mapping thing and locations, I'm just wondering, I know we talked previously about distribution of Narcan and community organizations getting Narcan. Like, are there Narcan vending machines in public housing or I don't know, areas where there's like a high density, just like residential, in building, just like apartment buildings or like housing developments?
So I don't have the list. I'm doing this on memory. And actually the Department of Health would be able to provide that. AIDS Care Ocean State is the vendor for the the vending machines. I do know that there are some in very high density areas. They actually just put one in Tanay Plaza.
Right.
So there was a vending machine there, Kodak. We can get, I'll put the link in when or I'll give you the information. You can find that. Is it on Prevent
It's on-
Overdose RI?
It's on Rory under, the Get Help map, so it maps out all the services within Rhode Island and toggle through, and then once the option is a vending machine, and we define where it is.
I can also say that there are efforts to distribute Narcan door to door in some of the high density areas. Someone knocked on my door. That's the supply of Narcan at my house.
Okay.
Maybe, yeah.
Yeah, our neighbors.
They skipped your house.
Other questions from the committee?
Great question. It's from this is incredible, Kathy, first of all, this amount of information and feedback from community members. I attended one of the breakout rooms, which was really helpful. It sounds like one of my big takeaways is that to keep investing in a lot of what we're already doing is a theme. I'm wondering if there's anything that surprised you that seemed particularly new, or is it more that there was really support for that emerging, fund allocations that we can be responsive in that manner to new things that are going to be on the horizon? Or was there something from your perspective that you wanted us to draw our attention to that was like new in your mind?
It's never new.
Yeah.
But housing, it's just something I always think about, but I'm gonna try to remember, because Senator Miller was in the breakout that I facilitated, and the transition, when it comes to housing, it's not just, we want to think about diversion so that people don't experience homelessness, and that is a huge issue with people who have substance use disorder, or they're using or drugs or whatever it may be. And I think, I don't remember your exact words if you do, and I had it typed out, I have it in the bigger form, and it was, we need money now. It was something like that, really bold, like we need money now, and people need to have a place to go now to get in there, and not even meaning procurement needs to be, that's not what you were saying. You were saying there needs to be an option now, like a subsidy for a person who can just, say, yeah.
So, we're narrowing it down to one conversation, but there is almost like emergency fund, like subsidizing is important as building, right? Building is 3-year curve.
Right.
Giving money to pay the rent because they're on the street is another tool based on that person who's most in need. And there are available. It's just like what we do here is, do we want to solve it? We should always do both 3 years out, and we should always do have the ability to write somebody a check for a month's worth of rent and a down payment at the same time. That we're building housing.
All people.
As many.
Right where they're at.
As many as we can, where it will have the most impact geographically.
Okay, not seeing any other hands from the committee. I thank you, Kathy. We're not doing public comment after this. We're doing public comment again at the end of the meeting.
I'll just interject quickly that there was a hand in the virtual room.
Yes, but we're not doing public comment
Okay.
now. Thank you.
No worries. Just want to call it out. Thank you.
Okay, it's a meeting. I acknowledge that. Take a breath as we move to this next subject. I want to use this meeting as an opportunity to present an updated set of expectations around how this OSAP will incorporate racial equity, and in particular racial equity, into its deliberations, decision-making, and recommendations to the state. You saw an earlier version of this document that everyone in the room has access to. We discussed at our April meeting. You'll recall that Lauren walked through this in April. This is an updated version. There's additional content added based on feedback we've received based on additional conversations with key stakeholders that we've had, interviews, input from the Racial Equity Work Group of the Governor's Overdose Task Force. What I want to do is to walk through this today and then allow you all to continue to deliberate, consider, marinate, because at our next meeting, I'm actually going to ask the committee to vote based on whatever additional feedback folks want to provide. And I'm going to ask us to actually vote on adopting and endorsing these principles for guiding, helping to inform our FY25 decision-making. That said, know also, and I'll say this again next month, this is a living document, as I think Marty, or maybe it wasn't, I think Marty said, someone said, as we, know better, do better. As we learn more, we can continue to refine and revise our racial equity expectations and practices in out years. But in particular, we're hoping that this will be helpful in helping inform our FY25 allocations. So let me walk through. As you'll recall, there are 6 categories for recommendations on how to incorporate racial equity into our deliberations. Through ensuring transparency, using strong equity-focused recommendation processes, carrying out equitable procurement, offering capacity building and technical assistance, ensuring shared and equitable communications and expectations, and carrying out a strong implementation plan. I'm not going to read this Word document. I do ask that you take it home and read through it yourselves, committee members. I just want to highlight a few points from each section. I also, before I actually get into the details, I want to also acknowledge we are also aiming to be consistent with the EOHHS's principles of choice, voice, and equity. We're not inconsistent, but we keep that as a consideration. This frankly is a more explicit way to present EOHHS's commitments to choice, voice, and equity. So not unaligned. Okay, so under ensuring transparency, the focus areas are on how we collect, analyze, and publicly share data about disparities in overdose outcomes and access to services, like today's presentation to start the meeting. Recognizing the intersectionality of identities and experiences, also mentioned in today's discussions. Involving community members and organizations in the data collection and analysis process. Offering multiple pathways for interested parties to provide input and feedback on these equity expectations. Making sure that information is publicly available in multiple languages and accessible formats. No disrespect to the professors in the room, but we don't all need to have, we should not need to have a PhD to be able to fully engage in these discussions. That maximum transparency be provided into the spending of settlement dollars. Again, we saw a significant step forward in that process with the presentation today. As you can see, these are principles and expectations. They are in some cases aspirational. So these are not being presented as if we have this on lock now, like we're doing all this now. These are what we are trying to build up to. These are the principles that we want to practice. These are the principles we want to espouse in our work. Under equity, using strong equity-focused recommendation processes, we're looking at ongoing training on equity issues and disparities, proactively sharing recommendations and progress reports in not just this setting, but also community-based spaces, especially focused on the most heavily impacted communities, which we're finding to be communities of color. Ensuring that there's an accessible and equitable path for community engagement in the recommendation process, including in multiple languages. Producing equity notes or equity impact statements for funding decisions. And continuing to address the social determinants of health, social drivers of health. Under carrying out equitable procurement, the recommendations are centered around having an accessible path to procurement. You notice there's a theme here about accessible access to information, accessible access to training, accessible access to procurement, for smaller organizations and BIPOC-led organizations, not just BIPOC serving organizations, but BIPOC-led organizations. Having equity-focused best practices in broader state procurement practices. We see this as our work as an opportunity to be a model for the state, not just for settlement dollars, but for state procurement. And that our procurements acknowledge structural racism and address supports like those through the class standards and ADA requirements. We want to ensure that the grant review committees are developed with equity in mind, including having folks with lived experience and service experience participating in the grant review process. Providing RFP review committees with training on equity, class, ADA issues so that they are fully equipped to take on that responsibility. Scoring grant applications with respect to how well they address equity, class, anti-stigma, ADA responsiveness, and explicit overt outreach to offer grants to culturally specific programs that will help to address the disparities that we are seeing in overdose exposure. Under capacity building and TA, offering a fair indirect rate in the procurement process for smaller that adequately support smaller organizations just as much as larger ones. Equity planning, equity plans from vendors in their contracts and in their review processes. Training for prospective or potential vendors on how to prepare state applications. It's frankly quite daunting and intimidating if you've not done it before to apply to a state agency for funding. So providing training on how to do that so that again, we can diversify the field of applicants and requiring vendors to complete training on diversity, racial equity, class and ADA topics. Under ensuring shared and equitable communications and expectations. I don't want to read the whole thing, but it's almost the whole thing. Developing, memorializing, implementing racial equity standards for our meetings and in our deliberations. Reporting on our deliberations in community settings. Conducting inclusive meetings. And class and ADA compliant materials and communication standards. And being outspoken and overt about our equity expectations, and in particular about our racial equity expectations. And then this is the key that these are good, and also implementation. So once this committee marinates, votes on these expectations, asking the staff, EOHHS staff, to develop an implementation plan. It would include how we apply these principles, how we monitor our progress, and how we report on progress. Those are the highlights. Does this feel like, you can give me like a thumb sign, or you can speak up and comment, big numbers if you like. Does this feel like we've moved the ball down the field from the initial presentation of draft and proposed equity principles? Is this progress? Okay.
So I think this is a great foundation document. I just have one question. If we should include something about consistently evaluating our practices to make sure that they're achieving the goals. For example, I'm thinking about the part about procurement and how using the most accessible path for procurement to best support the ability for BIPOC-led and small organizations to compete. Maybe having a principle about reaching out to these type of organizations that are not competing and finding out why to make the process better.
Thank you. Others, reactions? Senator Miller.
So I think these are all important, but I'm wondering, based on how we know procurement works and what's under the control of EOHHS and what is not, I would assume there would be at least an effort to have those who are involved in procurement outside of EOHHS to also consider these items.
Yes, it will require
Yeah.
Collaboration and commitment and application outside of EOHHS staff. I'm going to say it one more time. These are not necessarily all things that are happening now. They are to some degree aspirational.
Yeah.
And we're gonna, work it.
In fact, the direction would be to the entire state, not just to the HHS. That would be.
Anything else that you immediately feel, and again, you have time to send comment after the meeting, but that you immediately feel is missing or overlooked?
One thing, Carrie, might be the composition of the committee itself. I know many of the positions are set forth under this terms of the agreement, but if there is a way to incorporate some recommendation or principle in terms of the diversity of the membership of this committee, I'm not sure if that's possible.
Yeah, we don't, I don't know that we have much ability to modify that.
But I think that the MOU itself addresses, maybe not perfectly, and I don't have it memorized, but I think there are some provisions in there that address diversity of membership, composition of certain community represented. There are like certain positions on this committee that are sort of, you have large representatives from the community that I think, yeah, is it sufficient? I don't know the answer to that question, but certainly in a lot of ways it's a floor, not a ceiling, but I agree with that.
I'll also remind you, because I sometimes forget about this at different boards and things I'm on, there are term limits for some members of this committee, and you may not remember your term limits, but there is formally a term limit that we can actually, it would be term limit to start reminding people of, because we want to have the opportunity for additional, new voices to contribute to this work going forward. So that's a good point, that we should remind people of their terms probably at our next meeting. Let me take that back. I don't remember if there are term limits. There are terms.
There are terms.
There are terms. Okay. If you have any additional feedback, please do send it. I would say to myself and to Marty. You will look at this again in order to vote on it at our July meeting. Consider this as well. Does it adequately, you don't need to answer this now, consider it in your deliberations or send feedback in between. Does it adequately address racial equity? Drawing back to the beginning of the meeting today and the data that we saw, we are seeing significant disparities by race and ethnicity. Does this document adequately address our goals and our values around it, improving racial equity? So consider that as well in your feedback. Okay, thank you. Let me actually bring Kathy back up. I don't know. She doesn't need to come back up. She's sick of y'all. At our next meeting in July, we'll talk more about our equity principles. We will have more formal recommendations from the Governor's Overdose Task Force. We might try to include a subject matter expert or municipal partner for presentation. We're going to figure out how much time we have on the agenda. But we'll be considering recommendations for allocations for FY25. We're going to have a lot. As I mentioned earlier, you do have the right to summer vacation and enjoyment. If you anticipate that your vacation will overlap or that you will be drawn away from this meeting, please let us know as early as you can. I will harass again probably before the next meeting, just to ensure that we have quorum. Let me see what I'm forgetting. Marty has
one more little question.
Marty gets to come back up.
And we do have a lot of extra decks if folks from the community want to take a deck before you leave. I'm just going to leave them over here. One of the things that was mentioned in the racial equity document, and that you all talked about, it was a while ago, it might have been in the fall, was the standard indirect rate. And we have done the work that we needed to do sort of with our finance folks and looking at the way that we could implement this indirect rate. And I have here a memo from Secretary Sharis implementing what you asked 4 with a slight edit, which was necessary from the financial sort of audit perspective, which is the committee voted in favor of the proposal that organizational recipients of procured funds through settlement or stewardship, which you had said, would receive the standard 15% indirect rate. And here is the edit, unless they have a federally negotiated indirect rate lower than 15%. If organizations have that lower indirect rate, federally approved indirect rate, they need to receive that rate. So it will be lower than 15%, but otherwise, all organizations would receive that 15% rate. There were 2 primary themes that you all identified in that discussion: the importance of protecting against some organizations taking very large indirect rates to spend money on things that were not direct service towards the goals that you have, and that ensuring that small organizations have sufficient resources and are not penalized by their inability to negotiate a federally approved rate. Some organizations can, negotiate a 40% rate, and smaller organizations would always be stuck at the 10%. And with inflation being as it is, folks were concerned about those organizations. So the policy will take effect as of today through the secretary. That means that all of the procurements from any of the agencies that are doing this, so it's for BHDDH and Rhode and EOHHS, would negotiate this standard 15% indirect rate for those that don't have the federal. So just reporting on that, it's done now, and we will make this public, and organizations that are negotiating contracts should just know that as of today, this is the rate going forward.
Thank you, committee, for your input on that. We're going to move into public comment for one last time before we conclude today's meeting. Are there folks in the room or on the Zoom who would like to make comment, Jeff?
Can I leverage this opportunity to bring a question I had from a local police detective in our community? Was wondering about resources and or the effectiveness of a product that was put out by a company, Thermo Fisher, that supplies TrueNarc narcotic analyzers to law enforcement agencies. Allows them to test packages, see what's in there, kind of protect themselves. If anyone has familiarity, maybe offline, would love to, there's places I can point them for resources to purchase them, or the effectiveness of whether or not they're productive with them.
So we've used them. The effectiveness of it, it will tell you what's certain the substances are through plastic. It's a safe way of testing, but I think when it's basically where the scan is, as far as the reliability, where the scan is actually pointing is what it's detecting. So if the substance had, fentanyl, cocaine, heroin, it's mixed within the substance. It may detect all 3. It may only detect 1 or 2 of it.
In terms of resources, the local department purchase those, and any guidance?
Yeah, I mean, we can talk offline if you want to put me in touch with that, because there's several agencies that have it.
Great, thank you.
I don't know if this is already on the Pori site, but if not, it might be valuable to list some of the test kits, test suppliers, and the quality of the evidence around their reliability and accuracy. I don't know if that already exists, if anyone knows, correct me, but if it doesn't exist, that might be a useful tool. I'm just sharing this with the universe if people who can influence that. Useful resource to have on the Pori site for municipalities.
Yeah, right now we have a page focused on the fentanyl test strips, which is our most popular page actually, but our intent is to expand to more drug checking options, Carrie.
There's also Test RI is on the Pori website, which provides some of the results of the research project that is happening now. And it's showing the results in some of the drugs that we're seeing. Through that.
Thank you. Others for public comment? Hallelujah, it is 2:57, not 3:07. Congratulations. I move that we conclude today's meeting and I thank you all for your time.
And I will say that at 3:15 or 3:30, there's gonna be between 3:15 and 3:30, fire alarm testing. I thought it was a fire drill. It's not, so you don't have to leave, but you're gonna hear us.
Brandon, safe travels. Enjoy. Tomorrow night.
Is it busy?
Yes. Yeah, that's great. I was like, oh, yes.
Yeah.